I'm Dr. Swati Chantil, and I am practicing pathology for last 3 years now. And this is the case which is like encountered most commonly by any pathologist, no matter wherever he or she is practicing. Because tuberculosis is so common in India that every fluid you get, every pus or purulent fluid, pus you get, anything like knee joint fluid, pleural, pericardial, and ascitic. Any fluid which you get should be excluded or diagnosed for tuberculosis first. Then you jump to benign reactive cystic diagnosis, differential diagnosis. Then you go for infections, and then you go for malignancy. Because tuberculosis is very common because of the population density, because of the lack of hygiene, sanitation is so poor, and droplet infection is very easy in our country. And there is a lot of lack of patient compliance. Like when a patient is on ATT, he or she misses that dose and it converts into resistant TB. Now, need something for that resistant type of strain. So patient, because of lack of education, literacy rate is so low that we have to deal with TB on a regular basis, and that's why diagnosis of TB should be 100% correct. This is the ideal picture. What you see on the screen is the ideal picture of TB. However, because of a lot of antibiotic misuse and people because they hide histories and all that, you do not get an ideal picture. At least in my opinion, I do not get an ideal picture until and unless patient was not touched by any physician and was not given antibiotics, assuming that maybe this lymph node is infectious in nature. So, what we get? Lymphocytes. We start with lymphocytes. In this, you add plasma cells. So, what lymphocytes look like? How do they look like this? So, this blue color would be, as you can see, there is this whole sheet of lymphocyte here. So collar of lymphocyte, we'll see. Collar of lymphocytes, we will see. And plasma. So lymphocyte with eccentric nucleus on the side will be plasma. So we'll see plenty of plasma cells along with lymphocytes. And it will be like a sheet around the necrotic area. So that will be there. And then epithelioid histiocytes. Now, modified macrophages, very important and pathognomic of granuloma. So if you see epithelioid, start thinking tuberculosis. If you see necrosis with epithelioid, you are almost 100% sure that yes, I am dealing with tuberculosis here, no matter what the site is. We are not concerned with the site, that can be wrong, but if you see epithelioid, if you see necrosis, just go for tuberculosis straight away as a suggestion, and then you can write another few differential diagnoses if site is not very do not have nice predilection for tuberculosis. Multinucleated giant cells, yes. Langerhans type, we get that. So multinucleated giant cells with a lot of nuclei in one cell, epithelioid cell, like a boomerang. So if you remember Mowgli with that boomerang, he used to throw that away and then it used to come back. That shape was like this. Or sometimes people they call it slipper, but I do not see any slipper. I always see boomerang because maybe I was watching lot of Mowgli episodes when I was small. So epithelioid histiocytes you will see, multinucleated giant cells you will see, lymphocytes with plasma cells, surrounding it like a collar, you will. Now, let's see which cell is which. As you can see, this makes a boomerang. Okay, bang, bang. Okay, boom, bang. Lot of epithelioid macrophages. Let's not get into theory, just the practical part, that how you will see it under the microscope. Because nobody gives a damn about theory. If you are practicing and sitting in the market and you are asked to do make a diagnosis for tuberculosis ASAP. So, for example, you have done performed FNAC of lymph node, cervical, you got pus when you aspirated. Now that pus needs to be excluded for infection and TB. In infection, what will you get? You will get neutrophils, lot of neutrophils, lot of degeneration, which does not look like gaseous necrosis at all. Neutrophils accompanied by few lymphocytes, few plasma, not plasma cells, neutrophils with macrophages and lymphocytes. But when it's TB, you start getting necrosis plus plasma cells plus lymphocyte plus epithelioid histiocyte plus and giant cells for lucky. Giant cell is like a cheat sheet. You get giant cell in this scenario, okay, write it 100% TB. But if you're not getting giant cell, maybe because you have received a fluid, maybe patient is new, TB is not very old, it's recent, then you will get necrosis, you will get plasma cells, you will get lymphocytes, you will get epithelioid histiocytes, like this boomerang thing I'm explaining. Then that giant cells is called like 4x and 10x of biopsy tissue of, of cervical lymph node having tuberculosis. You don't have to see anything on 10x and 40x. It's just like, okay, I see necrotic part here, okay, and then I see, yes, granulomas. Yes, I see granulomas. How? Organizing lymphocytes, epithelioid lymphocytes, lot of necrosis in the middle. That's how we diagnose TB in just one look. Okay, but go forward, you take some higher magnification, take the help of it, study the cells properly. But just by the look of it, it looks like tuberculosis. Yes, it can be another granulomatous tissue as well, inflammation as well. It can be another disease which we can cause granulomatous inflammation. But because we are living in India, tuberculosis should be highly suggestive. Nobody can be 100% sure of TB until unless proven otherwise. And what is that? By TB PCR, by gene expert. So when we are saying that we think that this is TB, we are just suggesting that it might be TB. It is not certain. Certain will be this. So if you are seeing tuberculosis picture, just write suggestive of granulomatous inflammation. Please do not try TB. You cannot make a diagnosis of tuberculosis histopathologically or cytologically. You can only suggest with further ancillary studies like TB PCR, gene expert, and AFB same, said in state. So never write diagnostic of tuberculosis. Always write suggestive of tuberculosis. That's the art of histopathology. You suggest only to be confirmed by either immunohistochemistry or by further molecular studies like PCR, gene expert, PCR techniques. That's what they are for. So use them, suggest them in your report. Now, this kind of slide can be quite confusing for people who are new. So I will say that when you're getting neutrophils here, okay, you get epithelioid histiocytes here, seeing fibrin strands here, get necrosis here. So Once you see tuberculosis, once you see neutrophils, will you will you think about infection? No, not in this case, because you are getting necrosis, you're getting epithelial histiocytes, you're getting giant cells. No, not giant cells. Yes, but if you see, there will be lymphocytes, there will be plasma cells. Yeah, okay, I see this plasma cell here, plasma cell. But this is a case of cold abscess. So do not confuse cold abscess with infection. Please do not try bacterial suggestive of bacterial infection because you see neutrophils. Neutrophils are here along with the complete tuberculosis granulomatous inflammation picture. So you are actually dealing with cold abscess. So mention your findings in your report and then write features suggestive of cold abscess. The tuberculosis should be excluded or confirmed by TB-PCR and CB-NAT. Every study, if you have done, just include your finding. If you have not done, then just suggest. So this is how we diagnose when the picture is a mixture of neutrophilic infiltration and lymphocytic and histiocytic infiltration. But please, when you see necrosis, when you see epithelial histiocytes, there is a group, do not suggest that it can be bacterial. Cold abscess is still tuberculosis, just the modified version, but do not write that it is not tuberculosis. Okay, this is a very common mistake made by new pathologists who are still, learning various manifestations of tuberculosis. So this is one.